Good morning, everyone, and I hope you're having a good Friday so far. We're here for the latest in our webinar series to discuss continuing healthcare within integrated care systems. I'm just going to give it 30 seconds or so just to allow a few more people to join, but feel free to use the webinar chat option. Just type in any questions and we'll try to sort of feed those in as we go through the webinar. I've got two distinguished colleagues who are with me today. I'll introduce them in a minute, but I'll just give it another couple of seconds before we move on. Okay, good morning. So my name is Seb Stewart. I'm the commercial director with CHS Healthcare, and I'll be facilitating our discussion on continuing healthcare within integrated care systems this morning. I'm absolutely delighted that so many of you have decided to join us on this Friday morning. I know we're all incredibly busy, but I do believe this is a very, very key topic, and I guess that sort of reflects the fact that so many of you are here with us today. One of the key parts of my roles is to identify ways in which we can continue to better support our clients and partners, both in the NHS and local authorities, and of course their patients and service users. And you know, this is particularly important at the moment as we head into winter with the increasing pressures that our services are facing with a number of massively significant issues. And you know, one of the things that both local authorities and the NHS have to do alongside those significant issues is, of course, move into the new integrated care systems. So what I'd like to do now is introduce Stephen Chandler, who's Director of Adult and Housing Services in Oxfordshire. Stephen, would you like to introduce yourself?
Yes. Good morning, everyone. As Seb said, I'm Stephen Chandler. I'm currently the Director in Oxfordshire. A little bit of what I hope is relevant background. I started my career training as a nurse, and after spending a number of years in the NHS working up to and including trust board level, I moved into a joint commissioning role and then into local government per se. So in a way, integration has been in my blood and has been a factor throughout my career. I've been a director now in 3 different systems across the country, and the challenge, the opportunity that continuing healthcare poses has been a consistent factor in all of those roles. I'm personally excited about the opportunities that integrated care systems offer us on behalf of our citizens. And of course, it'll be great this morning to explore how integrated care systems can enhance the support that people receive, particularly through the support of continuing healthcare. So really looking forward to the discussion this morning.
Brilliant, thank you, Stephen. And I'd also like to introduce Paul Alliston. Paul, do you want to introduce yourself?
Yeah, thank you, Seb. Morning, everyone. My name is Paul Alliston. I'm a partner and solicitor advocate at Hill Dickinson. I suppose my background is within health advisory law, predominantly sector specific. So the majority of my clients are commissioners, acute trusts, independent health providers, and I specialise in commissioning law and deviations from that, the public law side of things, regulatory side of things, and then court protection, Mental Capacity Act, Mental Health Act, really wherever all of these interact with commissioning law. And I suppose, like Stephen, I've been engaged with this ICS process from the beginning, and it's interesting to see how it's all coming together or not. and really hoping to try and make sense of how it's all going to work, really. So that's what I'll hopefully bring to the table this morning.
Brilliant. Thank you, Paul. I think you're absolutely right that, you know, I suspect across the country, in some parts of the country, ICS, the development of that is going particularly well. In others, perhaps it's not quite so well advanced. But obviously, from a continuing healthcare perspective, you know, it's absolutely critical to make sure that the approach to having the right management, the right resourcing, and the right delivery systems in place is paramount. Before I start the discussion, thank you for everyone who also has contributed today by answering some our survey questions. There's some very interesting sort of feedback there. So the first question I think we asked was, what is your CCG doing to prepare for transition of CHC commissioning? Yes, and I think 70% of you felt that completing reviews in a timely manner to reduce the backlog was very, very important, and that 57% of you also felt that what was very important was understanding existing financial responsibilities in detail, including long-term liabilities. So what we're going to look at to start with is how the transition to ICSs will impact on the management and delivery of continuing healthcare. So Stephen, if I can start with you, can I ask you what are your views on how financial resourcing distribution will look like as we move into ICSs? I think you're on mute, Steve.
Oops. Yeah, schoolboy error. First question. Yeah, no, that's a really good question, and let's contextualize ICSs in my view, a relatively simplistic way. It's a relationship. It's a relationship based upon two significant partners, the NHS and local government, coming together. And of course, like any relationship, it develops over time. And like any relationship, there are processes and structures that are used to help that. So one of which is how do you deal with your money in that relationship? So some ICSs and some systems before ICSs had pretty detailed pool budget arrangements, integrated budgets and that. So in Oxfordshire, we have a massive pool budget arrangement with various components, various approaches to risk associated with that. So clearly, the responsibility for continuing healthcare is enshrined in law, and the assessment identifies who is legally responsible for funding the care associated with somebody meeting the criteria. That said, I believe systems need to look at their resources in the round and ensure that we're making maximum use of that. Finances are challenged in both health and local government. So again, having a very clear focus on that is paramount. So as the ICS develops and that relationship moves to, in a lot of cases, a different level, I see some great opportunities in managing the overall resources better. So clearly, continuing healthcare, as I said, legally the responsibility for meeting someone's needs, having fulfilled the criteria, has to rest with the NHS, and there's no plans that I'm aware of at a governmental level to change that. But in a way, and I suppose most people in the audience will have had some experience of the tension that sometimes arises between partners around who's responsible for that. I think the ICS, in developing that different relationship, provides a greater platform for reducing some of that tension. So in Oxfordshire, we talk about Team Oxfordshire with the basis on achieving the best outcome for the Oxfordshire citizen, and within that, the Oxfordshire pound. So when I talk to my CCG colleagues or my colleagues in our providers, we talk about a win, but only a win on behalf of Oxfordshire, not a win on behalf of the NHS or local government. That's not to say that there aren't tensions. You know, like any good relationship, it doesn't always run smoothly. But you know, if you keep that focus on in the context of CHC, the patient or the resident, I think it provides a good platform.
Thank you, Stephen. And I think one of the key aims of the ICSs is that greater integration, the collaborative approach, and but of course, one of the challenges potentially is around accountability. So, Paul, can I ask you, you know, how do you see collective accountability for organisations that are coming into the ICS working?
Yeah, so I suppose this is an answer I'm going to have to caveat twice. I'm a lawyer, I have to do that. But firstly, I'm not a corporate commercial lawyer, so I don't have the nuts and bolts understanding of how the structures are going to be implemented as perhaps my colleagues in health commercial might. And secondly, we're waiting for some regulation that's going to impact on this answer. But my reading of the legislation, the guidance at the moment, would answer this question in a short form as yes, collective accountability will be an aspiration, should be an aspiration, but it's not going to happen as of April, and it may be sometime post April. I suppose drilling down a little into that, it's obviously an issue that ICS sort of forerunners and footprints are grappling with at the moment, because the governance arrangements that are going to underpin them aren't clear, absent the regulations. You're going to have accountability within the ICB statutory body. The existing statutory roles of NHSCI in respect to commissioners won't change. You're going to have, or the legislation allows for members of the ICB to be appointed to the ICB who aren't employed by the ICB. So, as an example, you acute trust member or partner director, and they would be accountable via the ICB, but that would only apply to decision making made in respect of the ICB and not in respect of the acute trust that they represent. So that acute trust may be implementing or will be implementing the strategy of the ICB as part of the provider collaborative. So there's a bit of a fragmentation in relation to that at that level. And you've also got these members or partner directors are going to have split duties to separate organisations, which again is going to cause a bit of fragmentation in terms of accountability at the outset. Going down in terms of provider collaboratives, well, the accountability is going to sit with those individual trust boards. You've got the system oversight framework, again, anticipate no change in relation to NHSEI statutory rules. So any failings at that individual trust level to collaborate would be, or potentially could be, a breach of governance conditions. So, you know, the accountability is there in relation to that. And then really, we're given the need for subsidiarity, the majority of CHC functions are going to be implemented at place, is where accountability becomes, again, this is on my current understanding, even more fragmented on what we know now. So at present, it seems that the favoured place-based partnership structure is going to be a delegated committee of the ICB. But that model would stop accountability at the NHS, and really what's needed for that sort of whole system decision making and accountability are joint committees between the ICB, ICP, providers and primary care all coming together. Now, the legislation allows for these joint committees, but the regs are far from clear as to how that accountability aspect would be implemented. So again, current model the ICB committee, you're limiting accountability to the ICB. And I suppose really the reason why everything's so unclear is because of the flexibility that's built into place-based partnerships, and it's going to depend on area and what works best. The guidance, so the thriving guidance, recent guidance from September suggests that, you know, the governance arrangement should be secondary to sort of agreeing these shared goals and purposes of these partnerships. And it's wholly anticipated that this is going to take time. It's going to develop over time. And in the meantime, we're trying to create a culture shift to collective ownership, to management of quality concerns across the ICS, building towards that aspiration, as I said earlier, my short answer of mutual accountability before that can be properly embedded.
Brilliant, thank you, Paul. One of the key concerns I think that came out of the survey, moving on, was around workforce capacity. I think that 76% of you felt that additional workforce capacity would help your team, but of course that's easier said than done. But Stephen, can I ask you, what are organisations doing now in regard to workforce planning, and perhaps more pertinently, if they're not doing anything, what should they be doing in order to be fully prepared?
Yes, yes, thank you. You can't miss the challenges that workforce poses to the NHS and the social care sector. It's in the news every day. I think the ICS, in the broadest sense, provides an opportunity to look across health and social care in the context of its workforce. And again, I'm optimistic that opportunities will develop in that sense. So I'm currently part of what's called BOB, the Buckinghamshire, Oxfordshire and Berkshire ICS. So we have a very large footprint, and we've been having conversations at BOB level around particularly nurse recruitment, retention, not just in the context of the NHS, but in the context of nurses who might be required in nursing home provision, etc. So I think those are some of the early opportunities, particularly in the context of CHC. It is interesting when you look nationally about how many different variations on how the CHC process is operated, and by that I'm going beyond obviously the assessment, but then the brokerage or the commissioning of an individual package for an individual through to the reviewing of it, etc. And sometimes I think there's an opportunity to improve the efficiencies of those systems if you think about it from a partnership point of view. So local government is very experienced because of the numbers of cases we deal with when it comes to commissioning residential nursing provision, home care, etc. Why do we not maximise that experience when it comes to commissioning a placement on behalf of someone who's met the continuing health criteria? And I know there are examples where that already happens. So I think it's about drawing upon those experiences where systems have pushed further forward with their integrated arrangement. It's also about looking at whether there are roles that can go beyond just continuing healthcare, so that we're able to draw upon an expertise outside of what might have previously been seen as a defined group. So again, I think as ICSs, we will want to look at ensuring that the expertise that exists in CHC teams is not lost, but rather is enhanced, and the role of those professionals and those teams is recognised and valued, and in doing so, we remove some of the activity, if they exist, that actually could be done equally well, maybe better by others, and I'm sure there'll be members of the CHC teams who are on this call that can identify a lot of tasks that they're currently doing that they may say someone else might be well placed and skilled to do that. So I think it's about looking at CHC firstly as the specialist role that it is, but also looking at the business processes around it, and then thinking of the opportunities that come when you look at workforce across a much bigger footprint. And again, coming back to my last answer, thinking of it so in the context of Oxfordshire, we're probably thinking Team Oxfordshire, but then we're also thinking Team Bob. So where we can look at an even bigger footprint.
Thank you, Stephen. I love Bob.
Yeah.
That's great. Okay. So finally, in this discussion point area, Paul, a question for you. How do you see agencies collaborating together in the world of CHC moving forward as part of that sort of integration?
Oh, you'd hope it's going to be strengthened. You'd hope interagency collaboration would be strengthened by the ICS. You'd expect the systems board committee to have that opportunity to regularly review, sort out difficult issues, those cases where eligibility, there's complex cases where eligibility is sort of coming in or dropping out. I'd expect to be better handled, or put less opportunity for dispute or tension or friction, with better collaboration between the ICB and the place-based partners. You can see how those regular reviews and that collaboration between the agencies, bringing in primary care, for instance, could help patient flow through hospitals. You could address blockages in social care with this approach. So you'd hope or envisage that things will be strengthened by this. I suppose it's going to depend a lot on leadership. I suppose this doesn't just apply to place or CHC, but right across the ICS. Are the people in the leadership roles right for the role, and are they going to work properly in partnership? I mean, Stephen may be able to confirm or deny this, but my information at present is there's a bit of a vacuum in leadership in ICSs at present, so it's a bit up in the air. But the people filling those leadership roles really need to be able to bring along let's say if it was NHS, you've got to bring along the local government with them, and vice versa. To get this sort of permissive working relationship and collaboration underway. But I think it sort of touches upon something that Stephen mentioned in answer to the first question. It's going to take a lot of reorganisation of health and social care generally to get us there. I think I don't want to sort of be a harbinger of doom about this doom to fail, but I think there has to be a lot of reorganisation in terms of how these agencies collaborate before we get to that true collaborative stage. I also think it's going to vary area by area. Because the state of the current relationship between the partners is going to have a big bearing as to how it's all going to work post-April. So if you're starting from not an overly good relationship, and I appreciate that in my experience, there can be certain areas where there is tension between local government and NHS, well, that bad relationship is going to pervade post-April. So again, it comes down to leadership. I appreciate I digressed a little there, but it will be strengthened, I imagine, but there are risks and things need to be addressed, and I think it's central to the leadership role.
Thank you, Paul. Stephen, just a couple of questions that have come up. So one, and sorry, I didn't want to answer this in case I got it wrong, but could you remind us what Bob stands for?
Yes, of course. So Bob is Buckinghamshire, Oxfordshire, and Berkshire. So the ICS footprint goes across those three areas. So in Buckinghamshire, it's coterminous with the Unitary Authority. In Oxfordshire, with the County Council, and in Berkshire, it's across a number of the unitary arrangements. So in a way, it's complex because I think there are 7 local authorities within it. It previously was 3 CCGs. You know, as Paul said, it is about developing that relationship and leadership, not just leadership at place, but you know, in our ICS, it's across a variety of places. But there are some good examples of where it is working well. So if you want to go really big, if you look at the combined authority in Manchester, so that's probably the biggest scale of integration you'll see. I would say if you look at Oxfordshire, well, clearly nowhere near that scale. We have a joint commissioning executive that oversees the pool budget arrangements, which include within it the continuing healthcare budget, and that's where we have that focus on the Oxfordshire bit. I'm looking forward, always with a little bit of apprehension, to how that's going to work as we expand into Bob, or how Bob expands into Oxfordshire in a sense. But just finally, the 42 ICSs that have been created, they've been going through the appointment in a number of cases of chairs and accountable officers. CCGs are ceasing to exist at the end of this financial year, and the ICS takes on that legal responsibility from the 1st of April. So as Paul says, there's a lot of insecurity and anxiety because of the change, but I do think it gives us a much greater opportunity to focus on the people than there was before, and like every relationship, don't expect it to be rosy and to agree on everything from day one. You know, I've got a legacy of relationships where you know, they've made real strides because we had to work through difficult things, including how we manage our money, how we deal with intransient children, or you know, whatever. So yeah.
Thank you, Stephen. I just want to ask one more question to you quickly, Stephen. So someone has asked the question that isn't there a risk that with ICS members being so vast and varied that it'll be harder to achieve and recognise any accountability? Is this a sustainable longer term, or do you feel things will inevitably change again?
Well, as I said in my introduction, I've been in the NHS and local government all my career, and one of the constants in that has been change. So you know, I wouldn't bet on there not being change in the future. And I don't know if colleagues are aware, but there's currently a proposal for an integration white paper to be published by the government by the end of this year. It was in the Prime Minister's announcements back in September. There is obviously a risk that at such a large footprint that accountability becomes less clear, but again, as Paul described in his illustration of how the system's changing, there is a need to ensure that there's clear accountability at place, and you know, our model in Oxfordshire has that joint commissioning executive that has the detailed oversight of the commissioning plans, but also the expenditure plans, and also the day-to-day delivery, whether it's the activity, the finance, etc. And you know, I come from a local government perspective at the moment. My councillors are absolutely clear. They are not handing over any local authority accountability to the NHS. They are part of that arrangement, but they're not saying we're not accountable. So I think accountability is understandably on the forefront of everybody's mind.
Lovely, thank you, Stephen. So moving on then, what I want to do is now move on to looking at how organisations can prepare for ICS implementation. And one of the questions we've been asked is whether we can look at children's continuing healthcare as well, and the arrangements that are being made there. So Stephen, can I start with you first? Can you look at, you know, preparing for implementation? How can organisations prepare for budget setting, and how can they best build relationships with colleagues who they might not be working that closely with at the moment?
Yeah, no, yes, a really good question again. So I think in relation to budget setting, it is that very detailed analysis of current level of need, current expenditure, and based upon JSNA and other population predictors, what the likely future demand is going to be. One of the things I'm hopeful that the development of ICSs will help us with is in a way reducing some of that inconsistency that appears to exist around CCG expenditure on CHC. You know, I'm always, or I always used to look at to see where my CCG and local authority featured in the how much are spent per 100,000 population, etc. So I think it is about using those population predictors and ensuring that there's robust budget setting. I do think you can't just look at the continuing healthcare budget in isolation. You have to look at it in the context of other budgets that support older people, people with complex physical health needs, and you referenced in your question children's, I think as well. So our Joint Commissioning Executive in Oxfordshire has children's as an integral part of that, and our pool budget arrangement includes some of the children's expenditure. So again, I think it is walking slowly forward in each of those areas, building the confidence and the relationships. So our Joint Commissioning Executive has been running now for nearly a year, and all of the senior leaders, the Deputy Chief Exec from the CCG, myself, the Director of Children's Services, the Director of Public Health, we were all new to each other. So we didn't have a long-term relationship that we could build upon, but what we did have was, how can we use this opportunity to do better for the people that we're working with? How can we use this opportunity to perhaps find a solution to some of those wicked issues that existed in the past? So again, you can't underestimate the point that Paul made around the critical role that leadership has in this. And that is leadership in creating the environment for people to maximise the opportunity, but also the leadership in ensuring that the governance arrangements is robust and secure.
Thank you, Stephen. Paul, in what ways can organisations' workforces be educated, particularly in the light of some of the recent policy reviews?
So I think referencing LPS, for instance, huge on the horizon. As yet, we don't know whereabouts on that horizon. Should have been here. Well, it should have been April 22, but it won't be. Don't worry. But also you've got policy, strategic level policy, case law, guidance, the rest of it. It obviously has to, there's an opportunity with an ICS to centralise the sort of commissioning of this, of these issues, and increase consistency, which is a good thing. So I suppose LPS, I know that HEE via an HSE are putting in place training, so that is in the pipeline. But I envisage, and I'm sure you'll say I would say this, but I envisage a big role for people like me and law firms, because I've already been doing it in the Northwest to sort of ICS forerunners. So I've provided sort of a training to all the stakeholders in the sort of safeguarding side of one ICS in implementing the LPS at the ICS level. I've done training across another ICS footprint in implementing a legally sound choice and equity policy across an ICS. So, you know, in relation to that training, as I say, it's a good opportunity to improve consistency of approach. It's starting to get people together already, thinking about how to collaborate in terms of things like LPS, for instance. You know, what's going to be dealt with at place, what's going to be at the ICB level. Choice and equity Well, that was always a policy that was considered to be more trouble than it was worth. But it's, especially with the Equality and Human Rights Commission challenge to them. But it's sort of policies in general, no matter how well a policy is drafted or tweaked, it still needs to be implemented properly. And for that, there has to be an understanding of its key provisions, possibly some structural systemic change. Implementing the Mental Capacity Act appropriately, Mental Health Act, Human Rights Act. So as I said earlier, it gives a good opportunity for a centralised commissioning of training in relation to these issues, training in relation to assessment, care planning, which I think we're going to turn to later in relation to the PHSO report. It's centrally commissioned strategic level training that will, I think, be a real plus point.
Thank you, Paul. Stephen, what will be the influence of audit and CHC programme boards on delivery in terms of implementation?
So again, I think there's both opportunity and risk in this sense. So it is about making sure that the confidence, the assurance is clear, and I think that's where things like audit provide a valuable resource. I think CHC programme boards, if set up correctly and with partner involvement, can help ensure we reduce some of those inconsistencies and certainly reduce some of the tension that sometimes arises where people end up challenging, people being local authorities and NHS, challenging decision making. So I think they should help strengthen the decision making that we see around CHC applications. And again, I keep coming back to this point that while CHC is clearly an entitlement to individuals having met the criteria, CHC budgets need to be seen in the round of all budgets supporting vulnerable people in that area. So I think you see it specifically in relation to what it's legally there to provide, but you then see it in the context of a much broader financial position. So real opportunities. Again, coming back to Paul's earlier point, which I really like, which is the importance of leadership in each of these is going to be critical.
Thank you, Stephen. And we've had a couple of questions which sort of relate to my next question about how do we restructure, or how can we restructure service delivery models to benefit outcomes, efficiency and financial management. And we've had a couple of questions there as well about how can improved patient flow be achieved, which has historically been problematic. And also, do you see decision making within ICSs? Hold on, it's just gone blank. Within ICSs being more streamlined, or do you believe that it will take longer to get outcomes? Paul, I'm going to ask you both this question, but Paul, can I start with you, please?
Yeah, thanks. So I suppose I'm probably not the best person to explain how to restructure the service delivery models to improve, things like patient flow, streamline decision making, efficiency, financial management. You come to me when you've got an idea, and I'll say if it's legally sound or not. But I think something that Stephen mentioned earlier, but it's applicable here, is that we've already got some good examples about how CCGs and local authorities working in partnership have, at least on the surface, seem to have reconfigured operating models such as this. So I know Manchester, like Stephen mentioned, but you've got Leeds as well, Trafford. These are just sort of areas that I've got sort of knowledge of. Certainly seem to have been able to do this already. I appreciate they may be a bit further on down the line, but they've been able to do this, and it's possible. I don't know whether, I'm scratching the surface. I don't know if you lift the bonnet, it all falls apart. But from what I can see anyway, it's certainly a good example of how this is possible and achievable. I think working differently and collaborating from a people perspective is going to have a huge impact on efficiency and outcomes. Utilising people resources, I think Stephen touched on this earlier as well, from across the ICS effectively when it's needed. It'll be a big challenge, but it seems going to be essential for these larger footprints, and it will have that effect of streamlining processes, improving patient flow, for instance, bringing social care in earlier or whenever needed. That's just an example. In terms of outcomes, obviously it's a strategic vision of the ICS. My experience or my knowledge of outcomes-based commissioning and contracting doesn't seem to have the data behind it to properly kind of quantify or measure the difference that it has been made thus far in these good examples. It seems to get bogged down in data protection issues, but perhaps with the ICS there'll be a little bit more concentration on that and quantifying it and sort of getting the data behind this outcomes-based commissioning. I don't know, Stephen, if you've got something more concrete to add to that.
Thank you. Yeah, no, that was a good answer, Paul. I suppose one of the things, so there is a real opportunity here, but also there's an opportunity that the pandemic provided us with. So so during the pandemic, some of those things that previously were problematic, like data protection and data flows, we seem to find a legal way of overcoming some of the issues around decision making. We seem to find a way of empowering people to take decisions much quicker and much closer to the individual patient. And for me, we can't afford to lose some of that learning and experience. I think as we come together within a place component of an ICS, we should be looking at the CHC journey to see if there's opportunities to streamline it. I said earlier the example of how so in my current currently the CHC team who are in the provider trust, they do the assessment, they take the decision, they're validated with the CCG. They then broker or commission a package of support on behalf of the individual, and then they'll review and that. I think there's some elements of that the local authority might be well placed to do, some of that brokerage and commissioning, maybe some of the monitoring. Those are small opportunities. You mentioned, Seb, in your question, finance. I think, again, looking at the expenditure at a system level and making sure that we're getting maximum use of that. There'll be some colleagues, and because I can't see the attendees, I'm not sure if I'm going to insult anyone by this, but apologies if that's the case. Sometimes I hear people say the minute a provider sees somebody coming and they says this person meets CHC, it seems to add a significant price differential. Now, I appreciate people who meet the continuing healthcare criteria have very complex needs, but I'm not always convinced that it translates into the unit cost. So I think there's some opportunities there for delivering better value for the system pound, and if you look at it from a system perspective, there's benefits. So I think how do you do it? You try and give the people who know the system best a real say in how you design the future. So that's we're looking at in Oxfordshire how our system currently works, because we think there's opportunities, but we're doing that with the people who are involved.
Thank you, Stephen. So moving on, I want to look at how ICSs can be a driver for reducing variation, perhaps in CHC delivery, and also satisfy some of the recommendations that the Ombudsman made in their report in November 2020, particularly around, I think, two of the key themes there were around comprehensive training for frontline staff and better communication with patients and their families. And we've also been asked a question, which I think is relevant, is around are these new arrangements likely to impact on the current CHC processes in terms of checklist and DST completion and making eligibility decisions. So Stephen, if I can start with you, and from your perspective, how do you see local authorities playing a role in reducing variation in CHC delivery?
So again, if you take my position within the ICS, it's one of 7 local authorities. So in a way, this is where I see the ICS really helping, ensuring that for that much larger geographical patch, there is an improved degree of consistency. I think. So in my last job, which was in Somerset, one of the things we did was we did joint training. So that might have been training around the CHC process. So we had our social workers go along and sit alongside the CHC nurses doing that. That was to help ensure that we had, from a local authority perspective, a good understanding of the process, but also how we could ensure we could contribute to that assessment, so that confidence around the outcome was as high as it could be. Equally so, we did some training about the legal responsibilities of councils around care, which the health colleagues found valuable. So again, it's that bit about leadership and bringing people together around a common aim, rather than seeing CHC, well, that's the NHS's responsibility, and the only time I get interested in it is if I disagree with it. Removing that. So I think there are some opportunities there, and I do think we have to ask ourselves why there is such variation in CHC across the country, given that it is a national criteria. It's a single process, and one of the earlier parts of your question was, do I think there'll be a change to DSTs and checklists? I don't per se, because I believe they're part of the national process around decision making. So again, unless the government decides to change that, we will still need to follow the agreed process. I think the process is just the mechanism. It's confidence in using them that is the critical thing here. So anything we can do collectively to increase our confidence and reassurance is great. I might be tempting fate when I say this, but I'm not aware of any challenges that the local authority has posed in Oxfordshire to CHC decisions. You know, yeah, bloody hell, unheard of, perhaps.
That's great news, Stephen, and that I guess that sort of leads on quite nicely to a question for Paul, because I'm sure that's not the case across the country, but can the development of ICSs reduce the number of disputes and appeals around CHC decision making?
Yes. I suppose there's 2 elements to that. You've got your disputes with the individuals and families concerning. You've got the interagency disputes. As some of we mentioned the PHSO report. One of the main takeaways from me from that is relating to how there is a huge variation in terms of assessing needs and care planning, and the recommendations arising from that report regarding supporting skills and experience of CHC practitioners and disseminating that nationally, I suppose goes towards what Stephen was saying in terms of why is this so varied. I think PHSO was suggesting that there needs to be a more national approach, a more consistent approach, and it's something that I mentioned earlier in relation to training and education as a driver of that consistent approach. I think the joint training, Stephen mentioned in relation to interagency disputes is a really good idea. I think there's a lot of misunderstanding between local government, NHS in relation to where Care Act responsibilities finish, where CHC framework responsibilities start, or vice versa. And I think a little bit of a sort of mutual understanding as to the two would remove that sort of uncertainty and that suspicion as to, is that actually right? Is that their responsibility, rather than, it's a feeling that things are being pushed either way. I don't see any changes to the DST or the eligibility process as a result of this, but I do see a more unified and consistent approach to things like assessment and care planning. Example, the law requires CCGs to meet all of an individual's needs, assessed needs, which are to a large extent guided by the domains within the DST, but it's not limited to those. And you've got associated social care needs to be factored in. So I think there's a need for more individualized assessment of needs, and I think training can assist in doing that, and that might result in increased documentation or different documentation, or documentation following on from the DST, depending on how whatever approach an ICS wants to take in relation to that. And likewise in relation to care planning documentation. Appreciate it's generally considered to be the domain of the provider as opposed to the commissioner, but the courts and cases I'm involved with regularly are so insistent that if the package of care is the responsibility of the CCG or the ICB, as it will be, then the care plan is too. And I think there's going to have to be a bit of an increased understanding or documentation of care planning, again, to meet those recommendations from the PHSO. So yeah, I think it's going to be about training, really, to reduce those disputes across the board.
Thank you, Paul. And I think training is obviously and education is key to this. And so what I'd like to do now, in our sort of final set of questions, is look at some of the benefits that we think can be realised for CHC workers as we move into ICSs. And there have been a couple of questions on this. I think someone has sort of expressed a concern about addressing the ageing workforce in CHC, although someone has said that that actually not all, that there's a bit of a misconception that CHC workforce is ageing. Perhaps the substantive workforce is, but there's an interim workforce is very much more youthful, and perhaps how can we encourage people who work on an interim basis to come and work on a more substantive basis. And Paul, if I can go to you first, do you think there'll be more joined up working in the CHC workforce in the move to ICSs?
Yes, there'll be CHC workforces, work teams will be working together. I understand the model is going to be a lift and shift, so there's going to be rehousing of CHC teams within the ICB, however the place-based structure will look like. But there's obviously going to be a more collaborative approach as per the people plan. It's going to give the opportunity for the CHC workforce to work across the different settings, localities, trainings going to be aligned, as I already mentioned. So I think it will lead to more joined up working in terms of these workforce sharing models and arrangements, like secondments, for instance. In terms of addressing the ageing workforce, again, I couldn't give any confirmation either way as to that, but I think that the one workforce approach as sort of envisaged by the ICS is going to hopefully bring about or widen the scope in terms of who can be working within CHC workforces. And I think, again, like Steve mentioned, there are resources, staffing resources that can be drawn upon that may be actually better placed to sort of change the role and by extension sort of address this issue, you know, potential staffing shortages in the near future. So I think it's going to be positive, and I think that it's going to it will lead to that more joined up approach in CHC.
Thank you. Stephen, do you think there's an opportunity for reducing some of the bureaucracy that's evident at the moment through increased collaboration?
Yes, indeed. And apologies for appearing to dive out. I had a coughing fit. So I think, again, if you look at so we know and we clearly accept that the CHC assessment process has a very clearly defined methodology. That said, we've often built a lot of additional activity around it. How do you get decisions? Who's responsible, etc. So I think there is an opportunity to redesign that pathway. And I do think technology offers us a really good opportunity around that. I'm the Caldecott Guardian for the local authority, so I'm very aware of my responsibilities around that. But I don't believe there's any legal factor that prohibits the appropriate proportionate sharing of information. So me as a director have no right to have access to an individual's decision making, but clinicians and professionals who are involved in that absolutely do, whether they sit on the health or social care side of it. And I think the pandemic showed how we could quickly get through any confusion or questions around that. So I think use of technology, but also redesigning some of those pathways. And you know, you were talking a moment ago around the aging workforce. I think one of the factors around the aging workforce is the skill set that exists around CHC. So they are CHC practitioners, from my experience, are often some of the most experienced individuals in the system. So in a way, we need to reduce some of the challenges we're placing to their decisions and trust. Increase the trust around that, and again, the pandemic saw us do that. So I think there's some real opportunities there that we need to grasp, and you know, not see the change that ICSs bring as a threat, but rather an opportunity to fix some of the problems that exist here and now.
Thank you, Stephen. I'm conscious of time. We've got 3 minutes left, so I'm going to try and wrap up now. I have the feeling we could have kept going for another hour. That I apologize. There are a lot of questions that have come through on the chat, and I apologise that we haven't had a chance to answer all of those. There've been one or two that have been directed specifically to CHS around broad care and how people see us working with ICS in the future, and I'd be delighted to answer those. My email is sebastian.stewart@chshealthcare.com. So if you do want to ask any other questions, please feel free to come back to us. We have got another couple of webinars coming up. On the 18th or 19th of November, we'll be looking at developing skill and capacity within the CHC workforce, and in December we'll be looking at driving the effective management of personal health budgets. So please look out for those and sign up to them. We'll also be posting a post-webinar survey which we sent out to you, so please feel free to comment on that, what you thought of the webinar, how useful did you find it, how you think we might improve it, and of course any topics that you might like to cover in the future. I'd like to finish, if I can, by thanking Stephen and Paul for their significant contributions. I think that's been incredibly useful. I think it's clear from the discussion we've had today and from some of the questions that you've asked is that there are significant challenges as we move forward. I suspect that you know, what we're seeing is that in some areas of the country that move towards a better collaboration and increased integration is more advanced than in others. But also, I think quite encouragingly, I think we can see that most people see this as a significant opportunity moving forward in terms of how we support patients who need continuing healthcare, and how organisations are going to work together to provide a better experience for patients and their families. There are things that we need to do, I think, in order to achieve that. Leadership has been pointed out as a key aspect of this moving forward, and I think there are a number of good leaders who will help us drive through this process. Training and education is important, and that's one of the themes that I hope we'll be able to cover in more detail in our next webinar. But just to say thank you very much, everyone, for joining today. As I said, if you do have any questions, please get in touch. We at CHS, you know, see ourselves as a provider and a partner that complement existing services. So if you do need any support, please get in touch. Thank you very much.